Hello, I am Dr. Lymperopoulos. I'm an associate professor of pharmacology with Nova Southeastern University in Fort Lauderdale, Florida, United States. I will talk briefly about our recent perspective article on why epinephrine is preferred for cardiac arrest treatment. We argue in this perspective that this might be due to the fact that this hormone slash drug slash medication can uniquely activate one of the nine adrenergic receptor subtypes, specifically the beta-2 adrenergic receptor. So during cardiopulmonary resuscitation, the CPR, famous acronym, uh, um, vasoconstrictors are preferred in an effort to promote blood return to the heart so that you can kickstart the heart to start beating again. And consistently in the literature, epinephrine, also known as adrenaline, is routinely used during CPR, first-line treatment according to the International Advanced Life Support ALS guidelines for cardiac arrest, which recommend 1 milligram of adrenaline to be administered every 3 to 5 minutes during CPR until there is a pulse detected. However, there is this conundrum in the literature whether epinephrine is indeed the best agent to use over norepinephrine or vasopressin or other vasoconstrictors that can also promote blood return to the heart to stimulate the heart to start beating again. There are a couple of specific pharmacologic factors that may distinguish epinephrine, adrenaline, from the other vasopressor agents during CPR. And in our perspective article, we argue that one such factor is the activation of the beta-2 adrenergic receptor, which only epinephrine, among all vasopressor hormones, can robustly induce, not vasopressin, not even norepinephrine or dopamine. So this beta-2 adrenergic receptor activation equips adrenaline with more robust capabilities for pulse generation in the pacemaker cells of the heart, the sinoatrial node cells of the heart, responsible for the generation of the pulse. They are the natural pacemakers in the human heart. And also another unique action of the beta-2 adrenergic receptor is activation of the sodium-potassium pump, which can restore contractile function in ischemic or hypoxic myocardium during as in the situation of cardiac arrest where the heart has stopped beating. So these actions of epinephrine, of adrenaline, uniquely exerted via the beta-2 adrenergic receptor, probably are not shared by norepinephrine or other vasopressor agents, and may make it particularly useful in situations where simple blood pressure elevation is insufficient, such as cardiac arrest, where of course, you need to elevate blood pressure to help more blood return to the heart, but also you need to help the heart generate pulse. And adrenaline has been consistently shown in cardiac arrest studies and meta-analysis to be capable of generating pulse. Although the results on long-term survival after cardiac arrest resuscitation are mixed with adrenaline, one consistent key action of adrenaline consistently demonstrated in all the studies on this topic is that it can reliably help with pulse generation in a cardiac arrest patient, especially if administered fast enough upon the detection of cardiac arrest. Thank you for your attention.